Are there other ways that you think AI might facilitate some of the findings that your study uncovers? Or do you think AI might ultimately complicate some of the TMS processes that you were observing? Hi there, and welcome to Tepper Perspectives. I'm your host, Emily DeJay. If you've been enjoying this content, please like and subscribe. I'm about to talk to Dr. Linda Argote, the Thomas Lord Professor of Organizational Behavior and Theory and the Director of the Center for Organizational Learning, Innovation, and Knowledge here at the Tepper School of Business. Now, in this interview, I talked to Linda about some new healthcare-focused research that she and a co-author recently completed. The short version is this. Linda found that patients receiving trauma care have better outcomes when the teams of experts who care for them know each other well and have worked together before. There's a lot that's interesting about this finding, but here's something that I've been thinking about lately. In my experience, healthcare is an increasingly technical process. We turn to these sophisticated tools like AI, and we try to quantify just about every part of the healthcare process in order to turn medical care into something that's easy to measure. Now, there's an upside to that if we break things down into data points and then we can analyze them, and that can reveal problems or opportunities we wouldn't otherwise be able to see. For instance, there was a 2006 study of Michigan hospitals that found that when hospital admins realized central line catheters, which are inserted into large veins, were a big source of infection, they began tracking catheter-related infections and also what happened to those rates when nurses were empowered to enforce this safety checklist. And they found that when they did that, infection rates dropped significantly, so that safety protocol became standard. That's a great example of how turning medical care into a set of observable technical phenomenon and then measuring them can really make a difference. But even as we've spent the last couple of decades embracing this more technical approach to medicine, I wonder if we've come to habitually underestimate the relational, interactional parts. After all, the process of providing and receiving medical care is really human. A vulnerable person puts themselves into the hands of a capable expert, sometimes literally. And if we underplay the role that interpersonal connections play, I think we might be ignoring something that seems like it's nice to have but not crucial. But Linda's work really challenges that assumption. As she'll explain in the interview, how well the experts on a trauma team know each other, how familiar they are with each person's knowledge and skill sets, that has a tangible impact on whether or not their patients survive and how quickly they're released from their hospitals. I see two takeaways here. One, I think Linda's work reminds us that as much as we might want to treat healthcare as pure technical stuff, when everything can be reduced to measurable inputs and outputs, we ignore the more intangible relational parts of care at our peril. Second, and this is kind of a contrast, I think Linda's work reminds us that even if we want to stick to quantifying and measuring, we might not always be looking at the right things. It might not occur to us, for instance, to look at healthcare professionals' past experience working with other colleagues as key patients or key variables in patient care, even though Linda's work suggests that that's a really consequential factor. So we're not exactly solving the problem of healthcare in America in this video, but we're certainly complicating assumptions about what good care looks like and how you achieve it. Enjoy the interview. Dr. Linda Argote, welcome.
Thank you. It's great to be here, Emily.
We're so glad you're here. So I want to start with definitions because I think that's going to be important for talking about your research. So you have long studied this phenomenon called transactive memory systems, which we're going to call TMS, important descriptor. From what I understand, TMS is essentially where members of a team who have prior experience together, they understand who knows what and who is good at what. And as a result, they understand how to divide up their work based on that knowledge. Is that about right, or is there anything else you would add to that definition?
Yeah, that's an excellent definition.
Oh, thank you.
The concept started actually from Wegner, who used it to characterize a sort of specialization that occurs between couples, married couples perhaps, where one person might remember the birthdays on both sides of the family. Another person might remember where to get everything fixed, where you get that sort of specialization, and then you know who you can call on when you need something in a particular area. Yeah. Well, I was doing, my colleagues and I were doing some interviews at manufacturing plants, and there you see learning curves where if you look at cost as a function of experience, they decrease at a decreasing rate. And we interviewed managers and engineers about what was driving those reductions. And one of the things they said that had not been mentioned in the literature or had not been researched before was knowing who's good at what.
Yeah.
And they gave examples of how when they knew that, they could put the best person on the job. They knew who to consult if something unexpected came up. They needed advice in some area. And that, clicked with me. And a colleague of mine at the University of Pittsburgh, Dick Moreland, and I started working on that concept originally in small groups in the laboratory because we thought it happened in groups as well as romantic couples. And then that's, led to all sorts of other studies in the field and in the lab.
Yeah, interesting that started with married couples.
Yes.
And then, of course, we can grow that out, as you said, to groups. Well, speaking of groups, you've studied this in different ways throughout your career, but your recent study, you embedded yourself in a Pittsburgh-based hospital, and you watched their trauma care teams with the goal of seeing what impact, if any, TMS had on their work together, and then on subsequent patient outcomes, right? How their patients fared. What did you find in that study?
So, we were very excited at the opportunity. We worked with Drs. Jeremy Kahn and Matthew Rosengart at the University of Pittsburgh and Cindy Tang, who was their fellow at the time. And they provided the both understanding of trauma care and helped us think about measures. How would you measure TMS, for example? And then the access to the data. So that was a wonderful opportunity. And we found that if you were treated by a team with a well-developed TMS, you would spend, on average, 2 less days in the ICU and 3.3 less days in the hospital. And those are big, not just statistically significant, but they're meaningful differences in terms of reducing length of stay. That's good for the patients because less opportunities for infections and the like. Good for the hospital in terms of can treat more patients with more beds, their reimbursement, and their reputation. These things are tracked and published.
So like a tangible outcome
Yes.
for patients.
Yes.
That's so interesting. So you mentioned, as you were talking, measuring TMS and that you got some inputs from the doctors. I'm interested in talking more about that because TMS, the idea that it is, you have prior working experience, you know who knows what, and you have a sense of who's good at what. That is maybe it seems like kind of an intangible idea, maybe a bit of an ephemeral concept. I'm wondering how you went about concretizing that, turning it into something that you could gauge and measure empirically.
That's a great question because that was important for us to be able to measure it reliably.
Right.
Previous work on TMS had identified 3 indicators of it. So one was specialization, where people do different things according to their expertise. Another was trust and expertise. So if you did something in an area where I knew you had expertise, I'd be likely to trust you. And the third was coordination. We knew how to put the distributed expertise back together.
Right.
So we talked with our doctor co-authors and colleagues and some other, actually, a couple of other physicians were very generous with their time about how to measure that in the context of trauma care. And we asked them for either high and low, sort of a behavioral rating scale. What would be evidence of a team that was really bad on that versus a team that was really good on that? So one that I found interesting was the trust dimension. And that an indicator that was negative on that was if they took a task away from someone. Because then they realized that they couldn't perform the task.
Right.
That, time is of the essence in these settings, so they didn't want to wait for someone to give, try different things and try to get it right. If they can't get it immediately, they pulled it. So that would be an indicator of a weak TMS, that they had assigned the task to the wrong person. Other things would be if accepting suggestions from others, that would be an indicator of a positive TMS, that you knew people's expertise and you could accept suggestions. Or coordination, we looked at whether they duplicated tasks or omitted tasks, or whether all the tasks were done appropriately.
Yeah, that's interesting. So it sounds like to turn this into a dimension that you can measure with confidence, there are a lot of elements you're looking at that you're saying this adds up to good or, maybe strong or weak transactive memory. That itself is probably quite an undertaking.
We're hoping that this can, encourage the study of transactive memory in other settings where it might be hard to have people fill out questionnaires, which is the usual way transactive memory have been.
Oh, that's great.
measured.
So in addition to, obviously we're going to talk more about this, but an interesting healthcare finding, an organizational behavior finding, but a methodological contribution. Oh, that's very interesting.
We were actually coding tapes, the hospital tapes, every resuscitation to give feedback down the road about how well things went. And they gave us access to that. We would go over to UPMC or actually the medical school and watch the tapes. Two of my students at the time, Jerry Guo and Kiwan Han, were very key there, that they did most of the coding. So we had two people, and we didn't know what the outcome was because the outcome didn't happen till days away. So that was the strength of it, because sometimes if you know the outcome, that could influence your coding. But we didn't know the outcome. And we were thrilled that their ratings correlated quite highly. And then the ratings across the 6 items we had also correlated well.
You're taking something that, as I was mentioning, ephemeral, maybe difficult to quantify, and you're doing a lot of work up front, I imagine, in the study to quantify it rigorously enough that you have confidence that what you're saying you measure, you are actually measuring. That's great to hear. So I want to talk, we've talked about the study, sort of the methods of the study. I want to move out now and think, if we think more broadly about healthcare. One of the things that this is, from my view, and I think probably other people who, have received healthcare, have healthcare workers in their families, hospitals seem increasingly interested in quantifying medicine, right? This is becoming an increasingly technical field in order to better understand what's working and what could be improved. And there's a lot of examples of this, but like in, Kaiser Permanente some years ago, they started using vital signs to catch early warning signs of sepsis. And they realized it's pretty easy to track these warning signs. And you can sort of gauge, and then it created a protocol, right, that we can use. And just tracking these real easy to measure things produces great outcomes for patients. That's a great example of how something that would lend itself to being measured and is easy to measure, measuring it can make a big difference. But it seems to me, and maybe I'm wrong, and you can push back on this, but it seems like TMS doesn't necessarily work like that. It's not the kind of thing that you could immediately see how you could turn it into data. It's not necessarily an easy to quantify thing. I'm wondering how you see your findings about TMS fitting into this increasingly quantified, metrics-driven healthcare system.
We fully endorse the idea of being evidence-based, and indeed that's what we're trying to do, to provide rigorous evidence that would be compelling that this matters. The next step, one of the things we did was then look at how to predict PMS or what increases TMS. And we found it was experience working together. And we coded that very carefully. We had 2 years of data. We knew who was on each trauma resuscitation team. And then we coded how many times the various dyads had worked together, divided by the number of dyads. So very quantitative. What we're hoping is that these results could lead perhaps to, one of the outcomes could be to try to increase stability in the trauma teams. We're never going to get total stability, but to move the needle a bit, we think could be valuable. And that might be assisted by AI. AI might be, if you give it the data, it might be able to, or it could be an earlier algorithm even might be able to do that from industrial engineering and such, to come up with the teams that were optimal from an experience point of view, a working together point of view.
That makes sense. What's interesting, even though it sounds like TMS, when you were quantifying in the team, there are many factors that you're looking at and measuring for. You were able to reduce that complexity down to you could even days that, amount, length of time, duration working together becomes something much simpler to maybe feed into a system that could then schedule accordingly.
Right.
Very
exactly.
interesting. Okay.
Exactly.
So you mentioned AI.
Uh-huh.
I'm glad you went there.
Okay.
So your study ostensibly is not about AI,
Right.
and there's so much about AI these days. But I'm glad you bring it up because there's been interest in introducing AI into every field, I think, in in a lot of dimensions. But of course, there's been a lot of interest in introducing it into healthcare as well, including trauma care teams. Hospitals are beginning to be interested in how it can function as a kind of team aid, right, or how it can streamline processes that were messy before. There's, some hospitals have rolled out AI tools that like make recommendations for action based on a patient's history and their current vital signs. You mentioned that AI perhaps could assist with scheduling if we give it sort of something to aim for, and then it has duration of time spent working together. I'm wondering are there other ways that you think AI might facilitate some of the findings that your study uncovers? Or do you think AI might ultimately complicate some of the TMS processes that you were observing?
Whether we think of AI is also a node, and members are learning what it's good at and what it can do.
Yeah.
And I think that is a useful way to think about it.
Yeah.
And we're actually starting to do some work on that in another study, actually in the laboratory with one of our students. I think the ability of AI to process enormous amounts of data can be incredibly helpful in diagnoses.
Okay.
I think that's an area where it's already being used to great advantage, I think. But that strikes me as an area where having access to so much data, especially in cases that are rare, where a given doctor or hospital might not see it that frequently, to be able to access a wider set of data seems like that would be incredibly valuable.
Yeah, so even facilitating a team's knowledge building or knowledge gathering, perhaps. Yeah, interesting. So I want to end by thinking about how your research might pivot into recommendations. You've touched on this a little bit. So when you mentioned that you were able to maybe reduce something as complex as TMS down to a single variable duration of time working together, and that you can account for that perhaps in scheduling. That's a kind of recommendation that hospitals could use. Are there other recommendations that you see hospitals building based on the findings in this study?
We think the scheduling would be one direction to try to get more stability on these teams. The other one, whether there's training that could be done to perhaps when a new batch of interns comes on, which varies because interns have, depending on their specialty, they spend different amounts of time in the trauma center. But we may be able to find critical times when a new group has come on and then provide some training that could be helpful in building TMS.
Yeah, even training that might just alert them to some of what it looks like to build trust on a team, what it looks like to start to gauge who knows what. Maybe, do you think it would make the TMS creation for a team faster?
I think it could.
Yeah.
And the more we can, I think, give them realistic tasks, so whether simulations and Jeremy's the expert on medical education, but if we could have realistic tasks where people could see each other actually performing, and low risk. So no one's at risk. There'd be a simulation. That could be a way of people learning where their skill level is, right, to start with.
A new, maybe small but consequential dimension of one's like medical education when they're coming up through the ranks. Yeah, very, very interesting. Well, Dr. Linda Argote, thank you so much for talking with us today about your research. We really appreciate it. And if you've been enjoying what you've been hearing here at Tepper Perspectives, please like and subscribe.
The Tepper Perspectives podcast is made possible in part by the MBA Class of 2016 Technology Fund.